Hello friends. I'll be giving a little overview on this very interesting topic as part of our bicep that we did on 13th August. So, the context setting is this particular topic, gut microbiome in ICU, has got a little renewed emphasis in the recent past as having a bearing on other organ dysfunction. So that is the gist of this whole topic. Basically, your gut becomes dysfunctional or the microbiome because gut has a normal flora and that flora gets altered due to any reason which we'll talk about has a bearing on lung function, may have a bearing on kidney function, may have bearing on the neurological system, may have bearing on the cardiovascular function. So that is the understanding. And our understanding is how by changing or making the microbiome more healthy, could we alter the outcomes in ICU? So that is the whole context setting for giving an overview on this particular talk. So we need to understand how the normal gut flora looks or how the normal gut looks. So if you see in a very schematic representation, this is the normal gut. So the green one you see here is the mucus. So gut needs to have this nice mucus layer. Then gut needs to have this nice little rounded bodies. They are called goblet cells. And gut needs to have a small little junctions. You see, these are tight junctions. These tight junctions maintain the integrity of the gut epithelium. So if these tight junctions get loosened for whatever reason, then what happens? The translocation of bacteria happens into the blood vessel. And then the sepsis happens, bacteremia happens, organ dysfunction. So these are understanding. And gut has normal, mainly they have anaerobic bacteria. As you see, all these nice little bacteria floating around, these are all anaerobic bacteria. So this is way we look at the gut flora. And this is the mucin, this is the goblet cell. And so what really happens in gut is primary biliary acids from the liver, once they go into the gut, they are meant to be converted into secondary biliary acids by this gut anaerobic flora. So this is a normal, I will talk about what are the normal flora that we expect in the gut. They convert into secondary bile acids. And this secondary bile acids along with short chain fatty acids are the ones needed or quintessential for protection of these gut mucosa, mainly the goblet cell. So this goblet cell integrity is maintained by short chain fatty acid along with the secondary bile acids, which are derived from primary biliary acids, the conversion mediated by the anaerobic bacteria. So this is what is happening in the gut, and this is considered a healthy gut. So what happens in a diseased gut? If gut gets diseased, see this is how it looks. What is happening here? There is no mucosal layer, okay, and then the anaerobic bacteria seems to have disappeared. And because there is no mucosal, and you see there are no goblet cells. You can see there are no goblet cells. And tight junctions sort of are given way. So what this leads to? Leads to translocation of other nefarious or bad bacteria. They get translocated into the gut lumen. Because the bacteria translocates, the unwanted bacteria, sinister bacteria gets translocated, it leads to inflammation. There is some sort of a smoldering inflammation, and this inflammation leads to release of cytokines, interleukins, so on and so forth. And they are at a higher risk of developing bacteremia and other secondary infections. This is what happens in critical illness. So the gut is sort of having some sort of a low-grade inflammation, mucus layer gets lost, and your goblet cells get lost, your tight junctions get disrupted, and cytokines and interleukins get released, and they cause bacteria. Just another schematic representation. So what happens? So again, this is to show when there is reduced anaerobes, it leads to reduced mucus. So this green layer is the mucus, and this is leading to cytokines. And this, the healthy flora, when it becomes to unhealthy with other unwanted bacteria growing, that we call it as in gut microbiome pathobionts. That is the terminology that we need to remember. There is increase in the pathobionts. When pathobionts means increase in the non-commensal bacteria overgrowth is called pathobionts. There is expansion of pathobionts. So what happens? Because there is a pathobiont expansion, as I already indicated to you in the previously, there is translocation, there is inflammation, immune dysfunction leading to increase in the nosocomial infection. So simplistically, this is how we need to understand normal gut flora. When it gets disrupted, there is overgrowth of unwanted sinister bacteria, which we call it as pathobiont, and they get translocated, leading to some sort of a smoldering inflammatory process in the gut epithelium, leading to immune dysfunction and bacteremia, so on and so forth. So this is our understanding. And the microbiome. So this is another nice schematic representation. If there is a normal microbiome, this we consider as a normal microbiome. They have multimodal protective effects. So this microbiome has anti-inflammatory effects. So they prevent inflammation and they lead to production of short chain fatty acids. I already told primary biliary acids, they get converted to secondary biliary acids in the presence of these anaerobes. With along with short chain fatty acids, they are needed for the maintaining the integrity of goblet cells. So these microbiome are essential for short chain fatty acids optimization or functioning and production of short chain fatty acids. And for all my intensive care pundits, so short chain fatty acids are considered quintessential for maintaining gut integrity and they're commercially available. In India, there is not being manufactured. So these formulas are commercially available, which are marketed to protect our gut microflora. And your microbiome is needed for wound healing, and your microbiome is needed for reducing the inflammation and redox reduction. So these are the multimodal favorable functions of the microbiome that are needed for maintaining a good physiological milieu. So this is our schematic representation. So when someone is critically unwell, so this patient is on ventilator, so we understand he's critically unwell. This is the normal microbiome, which is anaerobe. So what are the normal microbiomes? I think as for intensivists, for all the trainees, you need to know a few names. So easy to remember, fecal bacterium is a normal commensal. As the name sounds, it's a fecal bacterium. So these names may be a little difficult. Blausia, bifidobacterium, fecal bacterium, lactobacillus, I'm sure all of you remember, and ruminococcus and subdoli granulum. So these are the common gut flora that are present in every individual. So fecal bacterium is easy to remember, lactobacillus is easy to remember, bifidobacterium, if you can remember this. When someone gets critically unwell, so these normal commensal flora reduces. And what increases? Pathobionts increases. So what are the pathobionts? I'm sure you know the names of all these organisms. Proteobacteria increases. Staphylococcus, they increase when someone is unwell. Enterococcus, this is how they look. So enterococcus increases and candida. So these are the pathobionts or pathological bacteria which tends to overgrow commensals. Normal commensals comes down and the pathobionts increase. So this is the changes that tends to happen in critically unwell. So when this change happens, when your normal gut flora comes down, pathobionts increase, translocation of bacteria happens, and your gut epithelium gets disturbed with the mucin loss, goblet cell loss, tight junction loss. We call that entity as gut dysbiosis. So where the gut integrity is lost, we call it as gut dysbiosis. So there are identified risk factors for gut dysbiosis. What are the identified risk factors? So identified is someone who is on TPN. That is a risk because you are not feeding. So gut dysbiosis happens. Someone you are giving indiscriminate antibiotics. So this is where the whole emphasis comes on use of indiscriminate antibiotics. I told you, Hrangic et al. Increases the risk of mortality. How does the mortality increases when there is inappropriate usage of antibiotics in individuals who don't use? Because your gut microbiome is altered and they are at a risk for secondary infections. So indiscriminate usage of antibiotics causes dysbiosis, and someone who is having a CVC line also is touted as, or any intravascular catheters, or gut dysmotility and epithelial breach due to GI bleed or any other reason. If their epithelial integrity is lost, that is also a reason for gut dysbiosis. And vasopressors, use of vasopressors also is a risk factor for gut dysbiosis. Altered pH of the GI tract and proton pump inhibitors. So all this PPI. So if you look at any ICU patient, At least 2 or 3 of these entities are there in our patients because vasopressors is commonly used, altered pH may be there for whatever reason, and PPI usage. That's why there is a de-emphasis on routine PPI usage because it can lead to dysbiosis and antibiotics use. So most of our ICU patients have at least 4 to 5 of these entities which lead to gut dysbiosis. So now, what this gut dysbiosis does? So there is a whole sort of a science that is evolved which says gut dysfunction leads to your lung problems and it causes brain dysfunction. It can cause kidney. So that they called it as axis. The different axis that happens. The one is called gut-lung axis. So here, as you see, the gut is affected with the translocation of bacteria. So especially your overgrowth of staphylococcus or enterococcus in the gut has shown to have a direct correlation of patients at a risk of developing ARDS. And they have found the des-aminotyrosin, which is normally present in the gut, in a healthy gut, is useful as a defense in influenza. So, which means if your gut integrity is good, then your des-aminotyrosin levels are good, and they act as a defense against influenza affecting the lungs. So, these are some science that has evolved. Then there's something called gut-brain axis. So, what it tells is if someone has colonized with enterobacteria in the gut, that has had a direct correlation with increase in the risk of patients having delirium. And if there are urease producing organism, there is increase in the ammonia production that can lead to brain edema and the brain dysfunction. So these are called gut-brain axis. And there's something called gut-heart-kidney axis. It is shown if there is lot of cytokine production and mucosal integrity loss, this has a direct correlation on the worsening of the heart failure. And the elements that are identified as a risk for this heart failure are trimethylamine and trimethylamine oxide. And these are typically produced by reduced butyrate producing organisms, which are typically Clostridium species. So if you have a Clostridium species, they produce reduced butyrate. And butyrate is a good one. Butyrate is something that are short chain fatty acids. They are good. If you are having a reduced butyrate producing organisms, you have more production of this trimethylamine, which leads to cardiac dysfunction and acute kidney injury. So this is gut, heart, kidney axis. So for all ICU trainees, gut microbiome can definitely be asked as an exam in DRNB. So at least you should be able to spell out these entities in the exam. So gut brain axis, gut lung axis, gut heart kidney axis. So what are the adverse effects? Because of all this organ dysfunction, the gut itself having a bearing on other organ dysfunctions, what are the ramifications? So the adverse effects of dysbiosis, obviously it can increase mortality because other organ dysfunction happens. It can increase the duration of mechanical ventilation, increases the ICU and hospital length of stay, and it can lead to severity of the ongoing illness and multi-organ dysfunction, and at a higher risk of hospital-acquired infection. So these are the multimodal sinister effects of dysbiosis, which all these endpoints, I'm sure most of the intensivists keep hearing on and off. So quite commonly. So this leads to all these other organ dysfunction. So now the biggest question is, what are the choices that we have to safeguard and protect the gut microbiome? What are the treatment choices? So there are 4 treatment choices. Early enteral nutrition, very clearly shown, right? There are umpteen number of studies, which are, there is a separate video on this. Early enteral nutrition has very clearly shown, Hale and et al. Has done a meta-analysis of at least 18 to 20 randomized controlled trials, very clearly shown early enteral nutrition reduces the risk of secondary infections or hospital-acquired infection by maintaining the gut mucosal integrity and gut microbiome was clearly shown. I won't go into the details of those studies. Most importantly, antimicrobial stewardship, indiscriminate usage of antibiotics where it is not needed can alter gut microbiome, puts the patients at a tremendous risk of impeding or disturbing or distorting your gut normal microbiome, leading to other organ dysfunction. And antimicrobial stewardship has shown to preserve the normal commensals, normal gut flora. And use of probiotics, there is a lot of articles, at least there are 50 articles on probiotics. And now the recent evidence, I'll show you the evidence, has shown probiotics perhaps may have some role in preventing ventilator associated pneumonia or secondary hospital-acquired infections. And the another new evolution that is happening is fecal microbiota transplantation, basically fecal transplant. This has shown to be very helpful in recurrent Clostridium difficile infection. So these are some of the entities that we have, all known facts, right? Most of you would have heard all this, but the new kid on the block, which is getting renewed emphasis, is probiotics, prebiotics, synbiotics, and fecal microbiota transplant is something that is increasingly trending at this point of time. So we'll talk a little bit on fecal microbiota transplant. As the name sounds, you are taking feces from a normal individual, considering that feces has all the good things, and giving it to someone where your gut microbiome is affected. It's as simple as that. So what are the advantages? Advantages is it has been shown to be successful in difficult to treat infections, especially Clostridium, and it is increasingly effective, and it is a passive immunity transfer. Basically, you are taking feces from healthy, where that feces, you expect them to have normal microbiome, normal gut flora, all those fecal bacterium or lactobacillus, and you are transferring it to someone where gut has become completely dysfunctional. There is an immunity transfer, as simple as that. Limitations is there can be adverse because if the donor feces has some infection, bacteria that can affect, and decontamination of antibiotics, and we do not know how sterile, whether the donor feces are healthy enough and they have all the normal commensals is something which is not tested or validated. And there are no large randomized control trials to say that FMT, fecal microbiota transplantation, is hugely successful. So these are some of the limitations of fecal microbiota transplant. So we need more randomized control trials to determine the effectiveness of fecal microbiota transplant. So how about prebiotics? So this is interesting. So there's a lot of evidence evolving. So for all the my intensive care trainees, there's something called prebiotics. There's something called probiotics. There's something called synbiotics. So you need to understand what is this. So prebiotic is all the fiber. So it's like inulin or butyrates, so on and so forth. And probiotics is live organisms like lactobacillus, enterogermine, all that you give. So you basically have pills which have this dormant lactobacillus or normal commensals. Synbiotics is combination of pre and probiotics is called synbiotics. So advantages is it is easy to administer, easily accessible, and they're naturally derived fiber. So when I say fiber, inulin is one fiber, or FOS is one thing where they have used, or they have used butyrates. So these are some of the, and short chain fatty acids also are commercially available, which is acetate, butyrates, propionates. These are all short chain fatty acids which are commercially available to augment your gut health. These are naturally derived, so less of side effects. But the limitation is we do not know the specific formulation that may suit our different patient groups, and there is questionable clinical validity of these prebiotics and probiotics because commercially there are a lot of prebiotics that are available, which is all the fibers. Basically, it's a naturally, so there is naturally existing sort of a fiber that we derive. So you have Naturalax powders, or you have inulin powders, so on and so forth. If you look into the Amazon, you'll find a lot of prebiotic fibers that are available. So we do not know whether any specific formula has to be calibrated to the specific disease condition of the patients. And over usage of this also may lead to, because these are live organisms. When you give probiotics, if someone is immunocompromised, this may itself put them at a risk of developing infection. So these are some of the limitations. And there is microbiota derived treatment, and we do not know the sort of a dosage. If someone inappropriately uses the dosage, this may put the patients at a risk for multi-organ dysfunction. So these are some of the concerns that we have when we are using probiotics and prebiotics. And they tend to have a better role when these are used prior to the disease onset rather than after the disease has started. So these are some of the caveats. So if you are looking at a core evidence, this is the latest meta-analysis on the probiotics. This is come in ESPEN in 2024 by the Chinese authors. So they have taken at least 18 RCTs in this. If you see, probiotics had a very favorable outcome. So if you see the left one, it's the probiotics group. And if you see, it had a good statistically significant outcome benefit with regards to mortality and all the other indices with the use of probiotics. But this is an evolving subject, so one needs to exercise discretion as to where you would use it as a routine standard of care. So the take-home message is understand this figure. We all have microbiome, which has a multimodal favorable effects, means wound healing, anti-inflammatory effect, reduces the redox reduction, and it increases, augments the presence of short-chain fatty acids like acetate, butyrates, propionates, which are all needed for maintaining the gut integrity. And if someone is critically unwell, be aware this normal microbiome gets disturbed and gives way to the evolution of pathobionts, where there is overgrowth of Staphylococcus, Enterococcus, Candida, Proteobacteria. And all this leads to multi-organ dysfunction, because which we call it as gut-lung axis, gut-brain axis, and gut-heart and kidney axis, which means they can lead to dysfunction of other organs, is what we have understood. The treatment choices, the easiest is start PW. The second easiest is practice good antimicrobial stewardship. And where you think the gut is very horribly disturbed, maybe there is a role of probiotics, which we can use, and it is easily accessible. And this has studies have shown, as you saw the meta-analysis, reduces the risk of secondary infections. And in for refractory Clostridium difficile infection, fecal microbial transplant always has a role, and this science is rapidly evolving. Thank you, friends. Request you all to submit your valuable work to Journal of Acute Care. You can visit my website to rehear to this lecture. Thank you. Thank you, and all.